first.
Hey.
Welcome, everyone. This is Dr. Megan,
And this is Joe Smith.
and we are back with an episode of Do Better Pod being recorded live. Thank you to those from the collective that are joining us here. If you want to have your cameras on, like Leslie does, you're more than welcome to, but you don't have to. Joe and I are going to be chatting and doing the actual podcast episode, but we highly encourage folks to participate as much as they would like to as well. And Joe, you picked the topic for today. Do you want to tell folks what we're talking about?
Yeah, let me bring up my notes just real quick. Um, but this was just something that as a traveling BSBA, I like to sit in my truck, and sometimes I like having nothing on at all. And this is my time where I think. And this is one of the things I've thought about as a episode that we could talk about. And it is, drum roll please. What should the focus of service intensity be? So this is like talking about what should the focus of prescribing hours be when you're prescribing hours for a client. I think this is a great one because as even as a veteran, can I call myself a veteran now? Like I've been in the field for a couple of years, so
Yeah, I
but
feel like you can.
yeah, but even as a veteran, this is something that's ever evolving. I feel like in our practice is the idea of what should a prescription strength be, and then also what should the focus of your decision on prescribing those hours and service intensity be. Um, because there's a lot of factors. And this is one thing I know when I was going through my coursework, we never discuss prescribing hours or how many hours to give or so I'm not sure where new BSBAs are at now, but or what college courses are teaching. But I know I would never had any classes or any instruction on okay, let's take a case scenario and decide on prescription strength for this individual. Um, so I think this would be just a great topic to talk about on a pause because, of course, we're all trying to do better in our field. And this is so relevant because you're not going to be, most likely, you're not going to be a BSBA and not prescribing hours. So,
Right.
Megan, what are your thoughts?
I think this is such a wonderful topic. And of course, this is one, again, folks who are on with us from the collective. If you have thoughts, especially if you received training or didn't, it would definitely be interesting to hear about people's experiences. So, the way back in, I don't know, 2010 or 11, maybe, yeah, it had to have been when we had navigation and we were just starting to expand and provide services to more people. I realized pretty quickly that no one, for some reason, I had my method in my head of how I was deciding what hours our clients would need. But especially for folks we were bringing on to work with us, most of them were newly certified and they didn't have any sort of training in that decision at all. And it didn't used to be that you even got to make that decision because the funding sources paid so little that it was basically like most kids were getting 6 to 10 hours in
Mhm.
our area based on the funding source. So it wasn't even like a decision really had to be made because the main decision was, is 6 to 10 hours enough that we can be beneficial for this family or not? And then we started having more and more opportunities where we could provide more services. And we had folks who were trying to recommend 20, 30, 40 hours for kids who definitely didn't need 20, 30, or 40 hours, or parents were coming to us wanting a higher level of service or a lower level. It was all over the place. So at that time, I looked at the main categories of skills that we would be working on and things that might interfere with progress. And I made our own little decision process, and we had a rating scale where we had it operationally defined and coded based off of how the person was performing in each of those different areas. And then based off of that scale, their total score would tell us how many hours they would receive. I don't know, Joe, if you ever saw that because it was something we were using while I was still running things, but then I don't know, you got certified after I was kind of like out of the picture. So I don't know if you ever were trained on that or not, but a lot of the behavior analysts
Yeah.
were. Um, it was part
Yeah.
of our intake process.
Yeah. And I was never trained on it just because I came in fully certified 2018, but I was still a teacher at that time. So I had like
Yeah.
one case and then that I inherited, and I didn't start full time until 2020. So by that time, it was fully Acorn Health, and that's when I we started talking about prescription fulfillment and prescribing hours.
Yeah. So I don't know why. I mean, I guess because I don't like research. I never did anything with that scale. It was more just for our own internal use. And but it's been nice to see there are a few people working on. It's kind of interesting that it's 2025 and we're just now starting to see stuff come out. So I linked an article in the chat here for those who are on with us, and then I also put it on the Facebook Live, and I'll put it in the show notes as well. So this is an article that was published in Behavior Analysis in Practice, I think. Yeah. And it was
2000,
published, yeah, 2023. And it's from Toby et al. It's the group is an amazing group. Little Star is the you'll see the references made to the clinic in Indiana. They've published quite a few pretty helpful things for folks. They have the apprentice model for supervision as well. So they in here they talk about how wild it is that there really isn't a process yet, that it's kind of just, random how people are deciding service intensity. So in this article, they go through the development of this tool called the Patient Outcome Planning Calculator, POPC. And they talk about the different areas that they focused on. And essentially, clients get placed into one of three tiers: high intensity, middle, or low. And then high, medium, or low. High is 30 to 40 hours per week, medium is 20 to 30, and low is up to 20 hours or community social skills type focus. And they had a pretty wide range of patients that they were serving to test out this tool. And they go through what the different assessments were that they were using with those clients as well. So right now, this is just a very early, there's obviously going to be more that comes out about this particular tool. But they looked at things like whether or not there was another diagnosis, and if it was autism, or if they were dually diagnosed with other things. And then they also looked at different research studies that support how they were creating the score. So a higher severity level for autism, frequent or severe challenging behavior, an absence of functional communication skills, and presence of social avoidance or withdrawal. So they have different studies they cited for how they came up with that. The actual questionnaire is 30. I'm trying to see the total. I think it's like 33 questions that they asked, and they list out the questions in the article so you can see what those were. And I think this is wonderful. They have in there that you can contact the lead author if you are interested in like beta testing this particular survey that they're creating. So I think if for folks who are, listening to this that are like, ooh, I need a more objective way to look at how I'm deciding treatment intensity, this might be a good option to see if they need any beta testers. And hopefully at some point it'll be something that, can be purchased as well. We also had during the Rejected conference, we had Allie McDougall who presented, and she's in Canada, and she presented on the model that they're working on. So now that's two different people. There might be others that are out there that I'm not familiar with, And of course, folks are listening that are definitely share those with us. Um, but I was really impressed with their specific tool because they're specifically looking at things like social communication skills, especially joint attention and gaze shifting and things like that are really known for predicting outcomes for autism specifically. And I think theirs is more geared towards early intervention, whereas the POP-C is intended to not, like, age shouldn't matter for the treatment intensity. So those are the two different tools. Well, the one that Allie was talking about is only internal right now. I think they're still working on development, but we do have, her presentation, and she goes over what they're doing and how they designed it. And then this POP-C, I think, is a little bit easier to access right now if folks reach out to the lead author of that article. Leslie's asking, did Mark Malady address this in the 5 hours or less presentation? So he also presented at the Rejected conference. For that one, no. Basically, he was talking about how they submitted a manuscript and it was rejected because one of the editors said nobody learns in 5 hours or less per week. So basically, they were trying to tell Mark and his colleague that, like, it's not possible that you all are teaching people with just a few hours a week. Like, that's just not achievable. And he's like, that's all we do. Like, we just have really good programming in place, and we've done a lot to design our programming to be individualized, and it's based on really good instructional design and generative instruction and all of that kind of stuff, so that they mostly serve adults and they're making really good progress with just a few hours per week, with a wide range of different diagnoses and skill sets and things like that too. So he didn't go over how they come up with anything relating to service intensity, but based on the funding source, I think that they have, or the specific entity that provides the services, that's just the amount of time they get with their clients, and they have to figure out how to make the best use of it.
That almost sounds like a therapeutic consult, almost like you only get so many hours a week to work with your adult clients. That'd be interesting. I'll have to look into that. But yeah, I mean, like I know, like while I was at Acorn, they were trying to start developing a system in-house as well. I know there's been talk about utilizing the assessments that you have conducted and use that as a way to gauge how many hours you should be prescribing. Uh, it would be interesting to see how, like, and just compare a couple different uh, assessments or like tools that they're using to see like which one has more accurate results or like which one is more efficient to utilize. That would be really cool. I am worried,
Mm-hmm.
with AI, like if there was ever a tool using AI to prescribe amounts, that's good. That kind of scares me.
Really?
Um,
Why does it scare you?
because because like for me, I would be worried about, okay, so where are you getting your data from? Uh, how are you controlling for biases, or how are you controlling? I mean, how do you really know the data that goes into that system to prescribe these amounts are accurate data? Um, how are you controlling to make sure that it's not it's not accidentally taking other people's data and combining it and giving you a number, but that's not really accurate. There's just a lot of like little factors like in the background that you have to ask questions on whether that AI system is built effectively. But I mean,
Yeah.
like if they could, like if you could, I say the POP-C and that's been accurate, and you compile all those data results from each POP-C that you did and put into an AI system, and you type in your numbers and maybe it spews out. I mean, I would be much more agreeing to that. But I mean, I don't know. I mean, like there's just a lot of like little new like you had to there's so many little things that you had to think about and whether or not that the system is best for that. Also, it's the I want to make this preference that, even with if you use this AI, you're the clinician, you make the final decision and say on that prescription too, because you're using your clinical judgment.
Yeah. Yeah. See, for me, when I think about the AI piece of it, just like the article talks about, and we've talked about already, no one in our field is really trained on this at the moment.
Yeah.
And the AI has much more capacity to be quickly trained on, these are all the different factors that should weigh in on deciding treatment intensity. And then you just essentially answer like a certain set of questions or put in whatever that information is, whether it's the info from POP-C or something else. And quite honestly, right now, like my concern with the AI is similar to what you said, Joe, but that it may not know yet, right? Like, how can we train it to do it if we don't even know what it is yet? Like, what
Yeah.
are the things that predict how many hours somebody needs of ABA therapy? There's not really a ton of research that's been done on that yet. And even development of the POP-C, this is based on their own clinical expertise, but it still needs to be now tested and see like, okay, we made these recommendations. Was that the right choice for this client? Did they make progress? And then there's so many different variables. Even if it was theoretically the right choice, something could happen from
Yeah.
another variable standpoint. That's like, well, we recommended 20 hours, but they only ended up coming 10. And well, actually, they still made progress, but would they have made more progress if they came 20 hours? You know?
Well, that's the other thing too, is like let's say you have a patient who you're working with and you're prescribing, I think 20 based on these results or like, my clinical judgment and where the severity of the level of autism, I'm going to prescribe 20 hours. But let's say the parent can only meet you at 10 hours. So what do you do in that case? Do you say like, no, I can't do that. Like this is my prescribed amount. If we can't meet that, then I can't work with you, you know, or if let's say you're like, okay, okay, let's just go ahead and work 10 hours and titrate it up. But you find out during the process that 10 hours is actually, he still is benefiting, he's still making progress that and making enough progress that, okay, well, 20 hours, like, yeah, we have 20 hours, but he's still making progress at 10.
Right.
And that's another conundrum is like, okay, well, where do you say, okay, you know what? Yes, I think the prescription for 20 hours is best, but some service is better than no service. And we already have a wait list for tons of individuals out there who need services. So where is the fine line?
Yeah, there's tons of different variables that come to play. And then there's certain companies that are like, we only do it if it's this many number of hours. And it's like, well, what about the kids that really need services, but for one reason or another don't fit into that little perfect window of either the therapy times that are available or the number of hours that are being required. And I think for the one question, if you prescribe 20, but the family can only do 10, I think sometimes it varies depending on the insurance company. And I would say I'm not an expert on medical necessity at this point because I don't have to deal with that anymore. So
Yeah.
I have the things I did before, but it's not fresh in my brain. I'm not as fluent. So if anyone else wants to chime in, but essentially like documenting this is the prescribed number of hours. And for this treatment authorization, we're going to do our best to meet that prescribed number of hours. And but then you have to be tracking and seeing, okay, with only the 10 that we're able to schedule at the moment, is the client making enough progress or not? But for a lot of insurance companies, if you're consistently recommending 20 and they're consistently getting less than that, the
Mhm.
insurance will say, then we're not covering this anymore.
Yeah,
So then you
because
have to decide, what are you going to only then recommend 10, but that's not what they need. So for me, a lot of those types of things are like, well, you put it down on paper and you explain clinically what's going on. Like 20 is the recommended. At this time, the schedule only allows for 10. We will be closely monitoring the data to determine if it's medically, if we're able to deliver medically necessary treatment given 10 hours a week. And we would expect to see even faster progress if we can get to the 20, but for now we're going to try to, see what we can get. But again, some insurance companies won't let you do that. So you have to know really well what the
yeah,
different funding sources are expecting and requiring.
yep. And I would say uh the other differences between is if the BCBA is providing the direct services compared to the RBT providing the direct services. I would think that there's a higher value with um, having a BCBA conduct 10 hours of direct services compared to an RBT conducting 10 hours of direct services too.
Yeah. Yep. I'm curious because I know, Joe, you have to hop off in a minute. Does
Yeah.
anyone that's on here that's watching right now have anything to add? Is there training you've done or certain resources you've used? Melanie's asking if anyone's used the POP-C. I put the link in the chat. I'll put it in again. And I'll have it in the show notes, like I said. This article isn't brand new, but it's new to me. Valeria talked about it this week on her Instagram, and I was like, ooh, I missed that article. How did I miss that? So thank you, Valeria. But I haven't used it. I don't know. Has anyone seen it before that's on right now? No,
I've
lots
never
of
seen
head
it,
shakes.
but
No.
that's awesome. Like
Yeah.
it would be
Has
interesting.
anyone used anything else? No.
I mean, I used a little bit of what Acorn was sort of starting to develop. Um, but before that was more like just clinical judgment and knowing the level of how impacted they are, and then the skills. I mean, the skills they are have deficits in. And if it's just social skills, then yeah, I mean, it's definitely a lot lower intensity. But if it's, um, communication and social and the nonverbal, then yeah, I mean, that's a higher level intensity of services.
Yeah. Leslie, do you remember when you first got into all of this, what the process was for determining hours?
Well, it's so interesting because I mean, I started obviously with my own kids' ABA first, um, in roughly 2011, 2012. And, there was no insurance reform in our state, so it was just a cash pay. And we did kind of max 5 or 6 hours, like sometimes less. Now, I recognize I took it to the extreme, of course, and did all the things. I sat in on every session. I took, it was paper and pencil data. Um, but there wasn't really even like that discussion didn't even exist then. And, there were no clinics. That wasn't a thing. So to see the evolution is interesting. And honestly, where we're at now, um, even like the place that I contract with that's not private equity, all of them that I know in our area, it's unless you're an independent contractor like I am and I can take whoever I want, the BCBAs are only taking the kids that will allow them to meet the hours that they are contracted to cover.
Mhm.
And, they need 200 billable hours a week. And that's just crazy. So
Yeah.
unless you have like 17 kids on your caseload, which is not manageable, they can't take kids that have 10 hours or less. That's who I'm taking, basically,
Yeah.
because those kids won't get service. Um, so there was no training. There was no even discussion of that. I vaguely remember, I think it came out of navigation, but I vaguely remember you sharing some sort of decision tree, but I can picture it in my head, but the number system isn't ringing a bell. But I remember you sharing some sort of decision tree um regarding service hours and, like, something of that nature. So maybe it was that thing you were talking about, or maybe it was a decision tree to address certain skill sets. I can't remember, but this is kind of ringing a little bit of a bell. Of course, that would have been like a long time ago. So,
Yeah, I have the decision tree is like how to determine how much naturalistic versus structured teaching, how much
mm,
like play-based versus and more discrete trial. I have a decision tree on that. That's probably what you're picturing.
it is, yeah.
Um, yeah.
Yeah, so I mean, now it's really sad. I love that people are talking about this topic, but with the way our insurance is structured and the tiered model of service, it it doesn't always serve the child.
Yeah. Well, one of the things that I thought of when you were talking, especially about the 5 to 6 hours, and Joe, if you need to hop off, feel free to say goodbye
Okay.
whenever you need to.
I'll see everyone
Are you
later.
gonna head out? All right,
Yeah.
bye, Joe.
Bye.
So um the 5 to 6 hours, and then you were doing, everything that you could to supplement that. And I think that's another big piece of the puzzle that needs to be incorporated when people are looking at treatment intensity. What is the bandwidth, the feasibility, the logistics of this person and their caretakers, their parents, their school, whatever their surrounding, stakeholders are to carry out therapy, to carry this over, to generalize and do these things when they're not in therapy. Because if there's families that can and have the capacity, whether it's because one parent stays home or they have, grandparents living with them, or there's just different support structures in place so they can do more and are motivated and want to, the number of hours could be less for that particular child. And then a child where that's just not the case, maybe it's a single parent, maybe the people, maybe it's an adopted parent, family with like the parents are a lot older and they don't have the capacity to do different things, but those are realistic factors that have to be considered too. And then of course the last part I'll talk about, what's happening in therapy, because 40 hours a week with a therapy provider who's not working on the right things won't really matter. Right? If they're not supporting and benefiting the child in the way they need, 40 hours could be two, could be one. Sometimes it might make things worse, or if they have a really good school that they could be attending that would keep them actively engaged and around peers, but you're taking them out to give them 40 hours of one-on-one. And even if it is really good therapy, is that actually best for the child, or should they be in the school environment where they can be contacting all of these other learning opportunities? It's just, I mean, the POPC is a great start. There's really good questions in there, and it helps get our wheels turning and start thinking about, but this is a long process. Like, I wouldn't be surprised. AI will probably help us, but I wouldn't be surprised if we don't have firm answers on this until like 2040 or maybe 2050. We'll probably all be retired and even by then, I mean, shoot, we might not even, everything we've ever done might be completely different with how fast technology is changing. So, but that's like when you think about how many therapy hours people are seeking or thinking are necessary, and the early research that was done in the field was all based on normativity. It was all based on, this is how many hours we need to make this kid act like a white boy who's typical. So how many hours do we need to help support this person to exist as the human that they want to exist as, and affirm and honor them and help them just have the strategies and tools necessary to self-advocate and navigate the world around them? That's probably vastly different, right? So I don't know. I think we have a long way to go before we can really say this is how we decide treatment intensity.
Yeah, I agree. And I mean, even, our state is, I'm sure many are cutting back on Medicaid services and, you know, um, again, we didn't have that, but I had our BCBA go into the school and work with the TA and work with the teacher. And the school systems aren't set up in my state to support kids that need that kind of assistance or direct teaching. It'll be a teacher with 12 kids with autism. She's lucky to get 3 assistants for her whole class, and so
Yeah.
there's just not that kind of support. So, uh, I mean, I don't know how the evolution of all of that will go, but now we're working, they don't want to pay for us, private contractors to go into the school to support teachers. So that's not going to help the situation.
Yeah. That's a whole nother factor that we didn't even talk about with how funding is changing in general right now in 2025. It's number of intensity of service hours may be a moot point. Like it might be you get 3 hours or you get like in Romania, I think no, Romania, I think is 40 hours per week. I can't remember. There's somewhere that I was talking to someone and it's like they have 4 hours a month. Everyone, and it's nice, like the government pays for it. Everyone gets the 4 hours, but that's all you get. What can you do in 4 hours a month? How can you be effective with that? And I'll tell you what, you can be, but you have to really know how to prioritize, pinpoint exactly what it is that you're not obviously the one directly providing services at that point. You're coaching and training the folks who are around the child more often, but it can be done. It's just not necessarily ideal. And we might all be in that position in the near future if the funding keeps changing and if the economy keeps doing what it's doing too. Such an optimistic and positive podcast we're having today. Sorry, everyone. But hopefully folks are excited about the POPC because it does look really interesting. I'm excited for people to check it out. Again, thanks to Valeria for talking about it on her Instagram and we can be excited and optimistic about that part. Does anyone have any other thoughts they want to share before we close out the podcast for today? All right. Well, then we will close out. And I don't have Joe here to do our little closing, so I'll just do it for everyone. Go forth and do better. We'll see you all next time. Bye.